having trouble with my card, and he sent his personal number home with me, and it says, and for a good time, and I'm like, oh my God, I gotta put this in the trash before Jeff finds it. Of course, he knows they give me a hard time anyway, but. Switched our scenario out a little, Michaela. Because,
whatever works for you.
Was,
working.
Coordinating with where we were wanting to go.
Okay, so that's good. I mean, we do have the online people as well.
Okay, we're doing online right now.
Or this group, I have the iPads. Yeah.
Hi, online folks. How are you? So right now we're getting ready to go through our Brazo tape, and we're going to take a bit closer look at the Brazo tape, and then we'll kind of work a code is what we're going to do. First of all, I need to know on your unit, where's your Brazo tape at?
I've only been on for 2 months and on one trip. I have no clue.
You have no clue? Yours? Up on top where?
By the OB, right here.
By the OB stuff.
And then we have another one in our, in the box.
Okay, and you have another one in the box, and no clue, okay?
Yes, it
Yours
was.
is in the Pete's bag, fantastic. So I think it's important, and how about online people? Do you know where yours are? They answer, anybody answering? Nope, okay. It's critical to know where your Brazo tape is, or your length-based tape. Very critical to know that. The other part that I want you to pay attention to, we're actually practicing with 2017's. Brazo tape, or the length-based tape that you currently have now, or should have now, is a 2019 edition. Hang on to your 2019 edition. It's not one of those things we're going to throw out. And the reason being, that's the most current edition that's out there. We'll see the changes come when the American Heart Association goes back to the PALS, and we look at what kind of research has been done over the last several years. And then after those last several years, then we'll have that update. Now, I would not expect that update to be maybe 2024, maybe 2025, somewhere in there is probably when we would see that update. So we all know that when we're doing an assessment, we do assessments. One of the things that we talked about, especially if we're doing our paperwork and whatnot, is we do what kind of an assessment from the head to the heel.
Oh.
We measure head to heel, but we still do a head to toe assessment. Yeah. Thank you for keeping that in your head, though. That's really important. And so I'll give you a quick scenario. So I had went out West River and did some training with West River. We pushed and we pushed and we pushed the fact that, it was head to heel, head to heel. And one of the little gals called back. So they had a 2-year-old that fell into a septic tank, and it was a horrendous extrication. So it took them several minutes, and we're talking more than 15 minutes to extricate. So by that time, you've got PD there, you've got grandparents there, you've got a whole lot of folks that are there. And they get the baby extricated, or I'm going to call a 2-year-old still a baby. They get that child extricated into the back of the ambulance, cleaned off as quickly as possible, start respirations. And she knew Brazo tape. And she put her Brazo tape down. She measured head to toe and got the baby into the hospital. And this, unfortunately, the chances of survival are really low on that. You're talking about cold fluid. You're talking about just all of the nastiness. To really be honest, it was a really crappy, shitty call. One of the points that she called me, and she was crying, and she had measured head to toe versus head to heel. The staff had also tape laid out on the bed, and what they did is they measured head to heel, and they backed those concentrations off just a little bit. So it's a catch, but the person that is hardest on us is ourselves, right? And with pediatrics, and that's kind of why I kind of preach that pediatric portion of this, is we see so few kids. The 16 to 18-year-olds, I think we do pretty good with those kids. 14 years old, man, that gets a little bit tougher. But when we're seeing these kids that are birth 3, 4, 5, 6 years old, they're really, really tough. And they feel like if I hand you a brand new baby chickie, you have to handle this baby chickie with care. However, in the process of that, they're way tougher than what we think they are, but when they crash, they crash. Or when your granddaughter smashes, then you smash. So we're going to run a scenario here kind of based on what we're seeing right now. what, it'll give it away obviously, but when we're looking at our pediatric calls right now, what kind of pediatric calls have we been seeing since probably September, which has been a little bit early, even into August through most of the year? What kind of peds calls are we seeing? RSV. So what is RSV? Yep, it's respiratory syncytial virus is basically what it is. So it is a virus. So does that mean that it only affects kids?
No.
So you could get it. Our grandparents could get it. It affects everyone. And then what else is tagging along with it? I'm sorry? COVID can tag along with it as well. Influenzas are tagging along with it. So we have some medically complex things that we're dealing with, especially with our peds patients. We're very fortunate. Early on, when COVID hit us in 2020, and for Sioux Falls, it was probably about March 15, 2020, when we really started getting hit with it, we had a huge concern of what was going to happen with our kids and how hard this was going to hit our kids. And we have all truly honestly been very, very blessed. I don't know that any of us would be standing in this room had we had COVID adults and then COVID and the repercussions that we would have had with kids and the amount of loss and death that we would have had. I don't know that any of us would have been able to survive the traumas of losing kids and adults as well. And now here we are with the RSV season. This is about capability. So what are your capabilities as far as caring for children? And then the capacity. So we know that our hospital facilities, if we're doing a transfer, it's really difficult for us to even get a kid into a transfer. Avera eCare, are you doing that in Avel eCare? Are you doing that yet?
Not yet.
Not yet. Anybody doing it yet? Not yet. So when we get to the eCare portion of it, I think the tape's going to be an important component of that. Even though their cameras can zoom in and they can see the things that we have going on, it will be an important component because that'll help us do treatments. So we know when we measure these little guys, what do we do? We have kind of a little bit of a saying. It goes from red to head. So we go from red to head and then we measure to the feet, right? So here's something to kind of keep in mind. This being the red, so it's the very top of the red. Be careful that your Brazil or your link-based tape doesn't get accidentally turned over. Even if, is everybody in here basic? Are we all basics in here? Nope. You would? Responder basic. Yeah.
She's advanced.
You advanced? AMT. So your drugs that you're able to give are
Microbial and treatment,
epi and a cardiac arrest?
no cardiac.
No. So epi and the world of anaphylaxis.
Yes.
Okay, and then start an IV?
Yes, and D50.
And D50, can you do a fluid bolus as well? Fantastic. The new process with epi and drawing up epi versus an EpiPen, where are you guys on that as far as basic responders? Your service hasn't pulled that in as of yet?
We had a meeting, we've had in services where we drew up only a bunch of sheets of an epi.
Great.
Switches and then.
So you got jacked up, right? So we're going to measure from red to head, and then we'll measure to the heel. With these little guys here, so if you take him for primary example, babies, what would you guess his age to be? Just out of curiosity.
8 months.
8 months, okay. 8 months, for him, he'd be, he could be 8 months, he could be 6 months, he could be 3 months. All depends on the size of the kid. These little frog legs, kind of keep in mind that he has little tiny frog legs. We want to make sure that those little legs are extended when we measure him. So if you want to go ahead and measure him, you guys can work as in tandem and kind of measure him, and we want to keep kind of a track of what color he measures in. So put your hand across the top of the head. Yep, that you have a good measurement. Needs to be flat on the bed. Straighten that little leg out. Fantastic. And what category is he measuring in? Great. Okay, so here's something to pay attention to. So when we're measuring in the gray, clean sheet is measuring in the gray. When we look at the gray as far as the resuscitation, if you will, and this is going to be really important for you to pay attention to, especially for fluid boluses and things, 3, 4, and 5 kilograms, they are all separate. The rest of the measurements are going to be estimated. So we take an estimate of the 6 and the 7 kilograms. But when you look at 3, 4, and 5 kilograms, what they're getting for their dosages for a medication or for a shock or any of those things is going to be just that. It's going to say we're going to do 2 joules per kilogram. So maybe for a 5 kilogram kid, it'd be, that's where we start. So there's different things that you're going to want to pay attention to. I would encourage you folks at whatever level that you are is to become familiar with it. If you have an ALS intercept, if you hang around at the hospital and you're helping in the hospital, you may be reading this Braille tape for someone. I can't read worth a hoot, so that's why my glasses are on the top of my head. If you look through them, it would be like, oh my gosh, I don't know how she even sees. But those are things to keep in mind. So we're going to give you this scenario, and the scenario is going to be you are called to a home, and the mom basically states her baby is not active, right? How many of you been in EMS for a while? Yep, been in EMS for a little while. We can become jaded very easily, right? Oh, not acting right, her first kid, whatever. Put that to the side. You need to pay attention to what's going on. If she feels something's not right, we need to figure out what's not right. When you enter the room, you take a look at him, he's got kind of a grayish appearance to him. So he's not quite the color of the gray on the Braille tape, but it's a gray blue. How do you feel about that already? Just across the room, not good. Okay, you can see when he's breathing, his eyes are closed, he's kind of limp, and as he's laying there, you can see his belly come up, and then he takes a breath, and then it sinks way down. And you can see that across the room, his respirations are really slow. Okay, so we're going to put his respirations maybe right in that 10 area. What do you want to do? How do you want to treat him? The first thing we would start with. Take vitals. You want to start breathing for him. So go ahead and start breathing for him. Good job. I like the way you got your hand positioned. Yep. Nice. Okay. And 1 breath every 3 seconds. You could, getting him started, you might consider 1 breath every 3 seconds. He's old enough, you can do 1 breath every 5 seconds. You have the hardest job. The very hardest job is if this child is breathing on his own and we're still trying to get air in. You want to make sure that you're getting air in at least when he's taking a deep breath. So paying attention to what's happening with that kid. So you've got respirations going. It's really hard to compress that bag, right? So when you compress that bag, you're hooking up the monitor, and as you're hooking up the monitor, your thought process is what?
His airway is open.
His airway is open, but that bag is hard to squeeze. Obstruction. And when we look at obstruction, even though his airway is, his mouth is open, where are our babies? Where are they obligated breathers? How do they breathe? They like to be breathed through their nose, right? So what's something we could consider with this little guy as we're doing this? I'd suction. Yep. I'd get some nasal suction in, get him ventilated, and take a quick shot, and then go ahead and suction him. So show you would use the booger sucker. Okay, so compress beforehand, pull out, and then take it over in the sheet, and there's going to be nasty green dirt. Nasty green, dirty, thick secretions, right?
Yeah.
So nasty, dirty, thick secretions, you're going to do it bilaterally and then get back on your bag. when you get your monitor hooked up to this little guy, his O2 sats are 76%. So 76%, you get your little EKG pads on him, and his heart rate is 40.
You're gonna start compressions on him.
Okay, so you're gonna start compressions on him. So what are we gonna do? Oh, she's gonna wrap her hands around. Yep.
15 to 2.
Yep, so 15 to 2. So he really needs, what would you do as observers so that I'm not doing it? What do you feel about her compressions?
Faster
Yep.
and deeper.
Yep.
Okay.
Get
1,
the-
2, 3, 4.
Yep.
Faster.
Even faster, you got, honey.
It's hard from this
Okay,
angle.
okay, so if it's really hard,
Yeah.
so make it work for you.
Okay.
We're gonna make it work for you.
Okay.
And is that working for you? Your hands, you've got pretty large hands.
Yeah.
They're not too bad.
Yeah.
Your hand's probably gonna wear out, but don't be afraid to get in there and do your compressions like this. You really need to get in there and compress fast. And then after she does her 15, you're gonna do two breaths.
Mhm.
And it's nice little puffs. We don't want to hear them. Okay. Even faster yet, sweetheart.
As fast as you can push. Almost.
And you can sing "Staying Alive" or whatever you want in your
Stay on.
back of your head or whatever you need to do. Okay. And what would you be thinking? So let's put you all three on the unit. You guys are all together, right? Okay. So Miss R here, what do you want to do? You're on this call, and these folks are working super hard to take care of this baby. So chest compressions are resuming. What would you roll be?
I'm gonna do a rapid transport.
Absolutely. Absolutely.
Get him over there.
Absolutely. We don't have to do with this kid. We're done with that. But what do you think the hospital would like to know? So here you go. You do a rapid transport and shit to the ambulance day, right? You guys go rushing in with this baby, and then I'm gonna get a call from Carrie saying, "What did you just tell these guys?"
We're gonna tell him the age,
Okay.
respirations, pulse, blood pressure. We're doing 2-person CPR.
Roslow's color.
Roslow's right.
And-
AD.
Yep, and we have an AED. Would you put your AED on this baby?
Front and back. Or if you have
Yes.
PS, front and back.
Yes. I definitely would. I definitely have my AED hooked up. Doesn't mean you have to use it, but most certainly I would definitely have it ready to go. Remember, again, this is all about preparedness. The whole weekend that we've had is about preparedness, and to have it out rather than to not have it out. Pediatric patient or pads, yep, we can replace them. Yes, they're hard to replace and whatever, but I'd rather have them out and on rather than fumbling around and trying to figure out what I'm going to do with them after the fact. So with that, your heart rate basically kind of comes up, and as your heart rate comes up, we had a heart rate of what, 70? Or no, we were lower than 40. So your heart rate comes up to 70. Your heart rate comes up to 70. Your O2 sats start climbing a little bit. They're climbing up to about 86. What do you want to do? You guys are like way out in the country. So I'm that's my scenario. So now you're way out in the country. And she's got ALS, capabilities. So what would you like her to do? This baby's been sick for 3 or 4 days. And you call for ALS or somebody to come in and basically help you. What would you do with your baby, with this baby now?
I continue to monitor their vitals, this and that. I'd start an IV if possible on them.
A neb treatment? Okay, hang on just a minute. Let her finish your fluid.
But because they're so little, I wouldn't give them a whole lot of fluid, just like TKO.
So I'm going to back you up on your fluids. You're afraid of the fluids right now. It makes you a little nervous because they're so little, right? So what we know is, does anybody in the room have, are they driving around? And this is typically what we see. Right. So we got kids, when I do the college nurses and stuff, you know, I'm like, okay, who's got a gas tank and their gas tank's on E? And, you know, about 5 or 6 hands go up, and I'm like, would you make a trip to Sioux Falls from here? And one girl was like, yeah. And I'm like, how are you going to make it? She said, well, I'm going to call a friend. He's going to come get me. And I'm like, oh my goodness. Anyway, it's fun to do it. But the thing about this is he's had RSV. He's been sick for 2-3 days, which means most likely he's got some dehydration going on as well. So hypovolemia. I would not fear giving him some fluids. So he measured on the gray. So look on your Broslo tape, and everybody look on your Broslo tape, because she may be anxious. She's trying to get her IV started. She tried once. Now she's got to try the second time. She's got her IV in. She needs to give fluids. So on the back side, so we have resuscitation on the front side, but on the back side, it says fluids. Yep.
I'm gonna, if it's 3 kilograms, I'm gonna get 60. If they're 4 kilograms, 80. 5 would be 100.
Yep. So then you're going to give 100. How would you give that 100?
Bolus.
You want to give it as a bolus. So you worked very hard to get that IV in, right? So it's more than likely, hopefully it's a little bit bigger than a 24. It could be a 24, maybe a 22 if you're lucky. And you get that 22 in there. You want that to basically stay secure. If you're taking a bag and you're too much pressure is going to blow it. Here's what the recommendation is. It's an old school thing. Come back. It's a push-pull method. So what you would do is you would use either a 60cc syringe, or you could use a 40cc or even a 30cc syringe. You'll pull your fluids down and then you'll push. So our whole goal is to get our gas tank filled back up, right? As long as we know this kid doesn't have cardiac issues, which he doesn't because he's been sick. Get that first fluid bolus of 100 in, push it in, and it's not a slam, it's just a nice push. You get that nice push in, and you can come back and you can do another fluid bolus. So this kid's been gray the whole time. As you fill that tank, when you're filling that tank, you're going to see the legs start to pink up just a little bit, and then you do your second bolus, then you're going to see him starting to warm up, and he's going to fill up a little bit more, he's going to pink up here, and then you get your third bolus on. Hopefully you're getting closer to the hospital, your third bolus on, and then he may or may not start being aroused. Keep suctioning. If his respiratory rate changes and it starts coming back up, that's a good thing. But what other thing might you want to do with this kid?
A neb.
A neb treatment would be a consideration, something even before that I would do. Huh? You could do, yep, I would keep the oxygen probably going. I maybe even nebulize that oxygen. I'd probably keep the oxygen, like a humidified oxygen. But how about a blood sugar? Because he's not been doing well. Yeah. Everybody's like, oh! Right? So level of consciousness. Anybody who has an altered level of consciousness, we definitely want to take a blood sugar on him. This little guy's been through a lot. You know, he's had 3 days where he's been kind of feeling kind of rough, and he's not taking a bottle. Part of the reason he's not taking a bottle is he can't do what? He can't breathe. He can't breathe. Yeah, he's got all these secretions in his nose and he can't breathe. So hopefully we're getting to the point where we're going to start moving out RSV season. Realize that if you guys are doing transfers, and you may have already, that you're transferring maybe not just to Eureka, maybe you're doing transfers and now it's Pier no longer has a bed, maybe your transport's going to be a little bit longer. As EMS and at your basic level, you want to drive, I'm all fine and good driving, but I'd ask a nurse to drive, ride with you. We have that provisional capability. I've even in my world and capacity that I've actually had a doc fly with me. You know, we've had a kid, you know, we did the last rites for this child. This kid was super sick. Our doc did not particularly care to fly. She jumped on board. She bagged the whole entire time, and she made it through that flight just by staying busy. Critical incident stress debriefing, I think, is really important. Even though this child, and you know, we're going to let this child have a successful outcome. Maybe he doesn't get out of the hospital for 3, 4, 5 days, but in that process of that, we need to pay attention to how we're all feeling. kids will, they take a toll on you. I had a pediatric patient that, our station was like 2 houses down, and I was out in the county because we were short. And we had a pediatric patient that the grandmother backed up. He was 2 years old. She backed up and she backed over him. And they knew EMS was at the station. They ran over there real quick, like to see if they could get EMS. Nobody was there. I get called in from the county. It's at least a 10 to 15 minute drive, depending on how heavy your foot is to the metal. And he is obviously deceased. You have brain matter in the whole 9 yards, and then we had a language barrier as well.
Oh.
I called the code. We were able to do that where I was in the metropolitan area. I had friends check up on me, and one of them was a captain on the fire department, and I'm like, I'm fine. I am doing well. And went back to the station, and I was stationed out there the next day. And probably mid-afternoon, somebody comes out to the fire department station, and they're knocking on the door. Answer the door, and it's the father in his broken English wondering where we took his baby. So no one communicated that that baby went to autopsy and where we had that baby. And that's when I had my meltdown. Things to do is to not to be so proud that you don't seek support. We had a swing out on this station. It was a rural station. I did a lot of swinging, and I did a lot of talking with the firefighter who was checking on me. And my fortune was that I was able to reach out to a chaplain who was also a paramedic. And I spent a couple of weeks with him just decompressing and understanding that I needed to keep busy doing things. Like, even if it was something so simple as I went and got a backboard, went and got a sheet. On that call, I went and the mom was covered with brain and blood matter all over. And we got her a new t-shirt. I cleaned her up. Those things probably saved my career rather than losing my career because I was doing something that kept me busy enough. But and the more that I am able to share that story with you, the better I am.
What do you do with the language?
The language barrier. Typically, I had a friend on the fire department who was he spoke Spanish very fluently, but he was not available at that time. And this was a code. It was already a code. So you got fire department, police department. I mean, you have just a barrage of folks on there. Be a challenge. Questions, thoughts? Those of you that are going to get that e-care in the back of your truck, I think this is going to be a very valuable tool for you to have. Very valuable tool for you for the things that you're doing, especially if you're going to be drawing up epi. I know that the state has a protocol as far as what we're doing for the amount of epi that we're drawing up. I believe under 8 is going to be your pediatric dose, and anything or under the blue zone would be your pediatric dose, and anything over that is going to be more of your adult dose if you're drawing it up versus an EpiPen. So EpiPens, if you still have them, EpiPens please treat them like a loaded gun, because they definitely are that. We had one of my firefighters, probably he lost his cool, but I thought he was the coolest firefighter ever, and went to give his first dose of epi and popped it in, and he's like cussing, and he popped it into his thumb. We had a second one through your thumbnail. Had a second one. He pulls it out, gets ready to do it, and he pops the second one into his thumb. Right? So this guy, he's Italian, and he's a great cook in the whole neighborhood. Like, Frank, you just lost your points here. He ended up in the ED because think about the amount of epinephrine that he just had in his thumb. So he ended up in the ED, and they had to watch him pretty closely so that, because when you're looking at a vasoconstrictor, vasodilators, and all of the things that epi does. So I don't think he's retired now, so I think he still has his thumb. So.
He didn't do that again either, did he?
Right? I'm sure he let somebody else do it. Let the babies do it. But that's all I have for you. I thank you so much for your time, and this is just a phenomenal refresher that you folks do here. I love it. Glad that I was able
Too
to come
bad
up
this
and
is the
do it.
last year we can do it here.
This is a really
Isn't
nice
that a
site.
bummer?
It truly, honestly, is a very nice site.
Ah, but they're closing.
All right, any questions on that?
No, not that I see. Awesome. Thank you,
You're
Corolla.
more than welcome.